Good morning, Chairs Rogers, Griffith, and Guthrie, Ranking Members Pallone, Castor, and Eshoo, and members of the subcommittees. Thank you for the opportunity to be here today to update the American people on our COVID-19 response. FDA appreciates your partnership in ensuring our country overcomes this pandemic and in preparing for future threats. This pandemic underscores the importance of a swift and agile response coordinated across all levels of government and in collaboration with the private sector. While the pandemic has caused great loss across our nation through extensive communication, dexterity, and innovation, we've been able to mitigate the impact of the pandemic and prevent innumerable illnesses and deaths. Most unfortunately, the proven effectiveness of authorized and approved vaccines and therapies have been undercut by a constant flow of misinformation, causing many Americans to forego life-saving treatments, leading them to many unnecessary deaths and hospitalizations. Nevertheless, FDA employees have poured their efforts into COVID-19 response to protect the American people. I'm grateful for their tremendous work and to Congress for your support of these efforts. I want to provide a brief update on FDA's efforts related to COVID-19 medical products. First, vaccines. Currently, there are 3 authorized monovalent vaccines, 2 approved vaccines, and 2 bivalent vaccines that meet FDA's expectations for safety and effectiveness. The current vaccines reduce the risk of contracting symptomatic infection and remain highly effective at preventing serious clinical outcomes associated with SARS-CoV-2 infection, including hospitalization and death. Staying up to date on COVID-19 vaccination is the best thing Americans can do right now to protect themselves and their families from the risk of becoming seriously ill or dying from COVID-19. Second, diagnostic tests. FDA remains focused on speeding the process to get appropriately accurate and reliable tests in the hands of all Americans who want one. The agency prioritized at-home tests since the beginning of the pandemic, authorizing 30 over-the-counter at-home tests, resulting in hundreds of millions of additional tests available monthly to American consumers. Importantly, the agency has also detected numerous inaccurate tests that would have done substantial harm if allowed to have unfettered access to the market. FDA also continues to issue EUAs as appropriate for other types of devices and facilitates the availability of critical devices and supplies. Today, we've issued EUAs or provided traditional marketing authorizations to over 2,800 medical devices for COVID-19, which is 15 times more EUAs than all other previous emergencies combined. Third, we continue to expand the country's arsenal of COVID-19 therapies and have facilitated the development and availability of 3 approved drugs to treat COVID-19 and EUAs for 14 therapies. It's also important to note our critical supply chain work, which has protected consumers by preventing medical products that do not meet import requirements from entering the country. This includes continuously surveilling the medical product and food supply chains for potential shortages, disruptions, and contaminated or fraudulent products, with focused examinations on COVID-19 relief supplies. The agency remains committed to continuing the use of every tool available to us to continue to mitigate the threat of this virus and others that we have simultaneously worked to counteract, such as Mpox, RSV, and pandemic influenza. Many of these tools are thanks to the work of Congress and your understanding of the importance of preparation and addressing the needs of our supply chain before an emergency strikes. FDA employees are anything but complacent, and they'll continue to work to make sure that we're even more equipped to address any future threats. Preparing for future emergencies depends on using the many strategies that led to a successful response, as well as the establishment and refinement of authorities and flexibilities that allow the agency to identify and mitigate risks while promoting innovation outside the public health emergency. It's essential that we improve our system for evidence generation, that is, doing the right clinical trials and having access to the data that Dr. Walensky has brought up. For example, the COVID-19 pandemic also underscored the importance of both diagnostic test access and test accuracy, and the critical need for a modernized regulatory framework that applies to all in vitro diagnostics. After years of collaborative work, including with leaders of this committee, we believe the VALID Act would achieve this goal and is appropriately balanced. Modernized authorities would enable us to act faster, prevent problems, and allow for greater insight into FDA's regulated products for greater safety. We look forward to continuing working with you to ensure a continuation of our COVID-19 response, success, and future readiness. Thank you, and I look forward to your questions.
Thank the gentleman. We now have concluded our testimony. I appreciate all the witnesses giving their testimony. We'll move into questions and answers, and I will recognize myself for the first 5 minutes of questions. Dr. Tabak, I, along with now chairs Rogers and Guthrie, have sent the NIH 14 letters requesting information. Those letters ranged in date from March 18, 2021 to November 30th, 2022, and most have gone completely unanswered. We received responses from other agencies, such as the CDC, to our letters. It appears there was a standing policy at the NIH to disregard letters from the minority members of this committee. Is that true? Yes or no?
No.
So it's just incompetence that caused 14 letters to go basically unanswered. I'll take that as given. We sent you a letter on February 2nd last week requesting documents and information from the NIH related to the COVID origins and the EcoHealth Alliance grant to support our legislative efforts on pandemic preparedness and NIH grant management. NIH sent us over 580 pages of documents last night after the close of business and shortly before the President's State of the Union address. That consisted mostly of repeat documents already given out or made public. That's not true cooperation. So I ask you, is the NIH going to fully cooperate with our requests?
We will continue to cooperate fully.
You will cooperate on this request. Thank you. We sent the NIH a letter on November 30th, 2022, asking you not to destroy evidence related to COVID. Last week, we sent another letter asking that you, quote, take all reasonable steps to prevent the destruction or alteration, whether intentionally or negligently, of all documents, communications, and other information, including electronic information and metadata, that are or may be responsive to this congressional inquiry, end quote. Will you vow to follow this request and not destroy these vital records, yes or no?
Yes.
Thank you. Even though the NIH suspended EcoHealth's grants in July of 2020, before our COVID-19 inquiries began over grant noncompliance concerns, and later that it was found that EcoHealth did not follow important grant terms, the NIH subsequently gave a new grant to EcoHealth in September of 2022. Why would you allow a company who breached their contract with the NIH and failed to comply with some important reporting requirements to get more of the American taxpayer dollars?
We follow process. They were put under advisement of these deficiencies. They have been working with us to correct them, and that's why we proceeded.
But they can't correct the information that they didn't require their partners at the Wuhan lab to give them, to give you 3 years later. So we don't have the information that we learned last week was important in determining both the origins and how to treat those origins at an early date. They failed in a major respect. How can that possibly now comply with your processes?
And we have corrected with them their administrative shortfalls and continue to work with them. We are unable to disbar an organization.
So do you want authority from Congress to be able to disbar an organization that breaches their contract and fails to get us information from a subcontractor that may have had vital information in helping us to respond to the COVID-19 outbreak?
The shortcomings of the Wuhan Institute of Virology have been noted in the GAO report, as you know.
I know.
And they recommend that disbarment be considered, and this is something that, we will...
Do you need new authority from us to disbar?
We do not disbar that. The disbarment official sits in HHS.
All right. Should we add financial penalties to NIH contractors to ensure stricter compliance if they fail to meet their contractual obligations and to fail to give you vital records? Do they need a financial incentive that's a negative incentive?
We can't put such incentives, if you will, or disincentives in our terms of condition.
You can or cannot?
We can.
You can. I suggest you do so. Should we add financial penalties to the NIH if they fail to do oversight on important research being done with the American taxpayer dollars?
I can't speak to that.
All right. Dr. Tabak, from 2015 to 2019, EcoHealth Alliance gave multiple, NIH grantee for coronavirus research, gave multiple subaward transactions to Wuhan Institute of Virology. EcoHealth has serious deficiencies, as we've discussed. The Office of the Inspector General even confirmed this in a recent report. How do you allow that to happen without consequences?
So the consequences were the initial suspension, reinstatement, suspension of the grant, and we have worked with the primary grantee, EcoHealth Alliance, to get them back into proper order.
It does not seem sufficient to this member. I yield back to myself and now recognize the gentlelady, Ms. Castor, ranking member of this subcommittee, for her 5 minutes.
Thank you, Mr. Chairman. The witnesses here today represent the most important scientific institutions in our fight against the COVID-19 pandemic and other diseases, and I greatly appreciate your work and the work of countless health professionals, everything that you've done in facing down this virus and your work to save lives. Unfortunately, President Trump's early minimization of COVID-19, followed by numerous instances of pushing misinformation, eroded public confidence in these vital public health and health institutions at a time that we relied on them the most. This wasn't limited to the White House, however. In Florida, Governor DeSantis and his Surgeon General have peddled conspiracy-driven propaganda that runs counter to the consensus of every major scientific and health organization. The governor has actively discouraged public health protocols and vaccines. He's hidden data, he's withheld aid, he's put dangerous policies in place that have cost lives and have put Florida children and families at risk. So you have an enormous job to combat this misinformation and rebuild the public trust. So I'd like to hear what you all are doing to ensure that we're operating on proper science and that the public has trust in your institutions. Dr. Tabak, I'll start with you.
One of the programs that we've established is known as SEAL. It's a community engagement alliance where we do localized approach, partnering with faith and community leaders, particularly in underserved communities, to address all questions about COVID vaccines, therapeutics, et cetera. In the RECOVER trial, we are engaging patients and communities broadly, again, trying to build, work with them through trusted community voices.
Dr. Walensky, I'll ask you the same question, but I know you've undergone a very extensive review. It's been called unflinching in your examination of past mistakes by the CDC and how you improve going forward. You've done some reorganization, so how are you working on building public trust in the agency's mission?
Thank you. Yes, obviously, much of some of the challenges are challenges this administration inherited. They've been longstanding challenges at the CDC, and we've taken this opportunity to learn from the challenges of the COVID-19 pandemic. That includes sharing our scientific data faster, enhancing our laboratory quality, translating that science into clear, concise communications. I do want to highlight the real importance of mis and disinformation and how it has undermined our vaccine efforts. It is the case that we anticipate vaccine rates have gone, well, we've seen vaccine rates of incoming children into kindergarten have gone down from 94% to 93% just in this last year. That's 250,000 children not coming to kindergarten with being up to date in their vaccines. We are doing a lot of work at CDC, but this is not something that CDC can do alone. It's going to take all of our agencies, it's going to take all of the government, and every single one of us has a role in mis and disinformation.
I've seen it in Florida. The vaccination rates for children are down, and I know it's a direct result of a lot of the scare tactics and misinformation. Dr. Califf, I'm going to ask you to respond for the record, because I'd like to ask Dr. Walensky about the CDC's data modernization initiative. So it's so important that we aim to get, to empower the agency to get better, faster, more actionable insights on public health data. But I heard from folks back in Florida and all across the country, it was so outdated. We've given the CDC funds to modernize it. I know that's just a drop in the bucket. So what are you doing to ensure that the public has the most accurate data that's up to date?
So just to give you a scope of the problem, it took us 6 months to get data use agreements to receive data during COVID-19, and it was over 100 data use agreements. So we are working through our data modernization efforts to have a singular highway through which data pass so that data from your districts can come to CDC, and then we can give it back to your district.
Not by fax machine.
No, not by fax machine. And in fact, in those districts where we've stopped using the fax machines, there are data to suggest we've saved 140 million person hours, so that we know that these highways will work, and then we can receive those data from your districts, and we can give those data back to you so you can see what's happening in your districts and the districts around you, what threats might be at your front door.
So we save lives and save money at the same time. That sounds good. Thank you so much. I yield back.
Thank you.
General yields back. Now recognize the chairman of the Health Subcommittee, Mr. Guthrie.
Thank you very much. I appreciate it. And responding to what our ranking member said, we obviously have to listen to experts because we're not experts. But we don't have to give away our right to oversight. We're responsible for oversight of what's going on at the agencies. That's in our purview. I know we didn't have hearings when they were in the majority, but we are now. And quite honestly, Dr. Walensky and Dr. Califf, y'all have reached out to me, so I think y'all appreciate our role in oversight, and that's noted and appreciated. And so, and the reason is this, and here's an example. We're going to talk about school closure. I think we talked about that before. In summer of 2020, the Kentucky schools were getting ready to start back again. This is before you guys were in office, I understand that. And then the governor delayed, told schools they couldn't open. Then he went to a point of said, okay, I'm going to suggest you don't open or ask you not to open, but not force it. We had school systems say, we've been spending the summer getting ready. We're going to get open. We're going to stay ready. So they met in the fall of 2020, a handful of school systems in my district. One superintendent didn't want to meet, but the non-experts who were elected school board members voted it down, and they met, and the kids were better off for what the decisions that the non-experts made. And the governor even pointed out our school system, some of my superintendents by name, for y'all are going to cause problems. Y'all are opening your school system. Well, it didn't take too long to understand, not that there weren't any cases in our school system, but none traced to the school system. And we learned pretty quick the kids weren't super spreaders like they are with the flu. And not a single person from Frankfort went to one of our schools that were open every day and said, is there what are you guys doing to make it work? And so then you fast forward to 2021, and then the guidance, Dr. Walensky coming out from CDC, that was highly reported, heavily reported that the teachers union were involved in a line-by-line edit of the guidance. And it would have been helpful if one of my superintendents would have had the opportunity to apply. So it gets not just to that situation. I would like for you to talk about that situation, but also, you're the experts, but how is it transparent? How do we know? How can we have confidence in guidance when we have school systems meeting and meeting effectively, but then guidance came out that a lot of people used to keep I know you didn't order the school systems closed, but they used your guidance to do so.
Yeah, I appreciate the opportunity to speak to this. So I came in on January 20th, and it was among my highest priorities to get our schools open, and it demonstrated, the work that we did was demonstrated to be successful. So when I came in, 46% of schools were open. By the end of May, we had 63% of schools fully open, and by September, we had 94% of schools fully open. Among the first guidances that I released, I think within 3 weeks of my arrival, was how to get our schools open. That is the guidance to which you are referring, and I'd just like to speak to how we put that guidance together. We take subject matter experts. We have our scientists review the data, review the
Did the
science.
teachers union have specific, I just got so much time, I'm sorry, but did the teachers union have specific access to it that others didn't?
In a penultimate version, what we do is we look at our key stakeholders. We reached out to over 50 key stakeholder groups. That included parents, that included superintendents, that included teachers, because we really need to make sure that those stakeholders can actually implement on the guidance that we put forward. There was a key piece missing in that penultimate version, and that is, what do you do for teachers who are immunosuppressed, those teachers who are getting breast cancer treatment, teachers who've had a heart transplant? That piece had been missing. It was the reason that we request that feedback, is so that we can say what's missing to implement. And it was that piece that was changed after those discussions.
So are you going to do things differently, or do you feel
So
like?
we are strengthening our processes as to how we standardize and do that outreach, but I think that outreach continues to be critically important. We need to know how the end users will receive our guidance to understand that it is implementable for the.
We want to make sure that everybody has access from all parties.
And we did speak to superintendents and parents. We spoke to over 50 groups.
Thank you. And Dr. Califf, I understand that FDA has, people have said that has really good guidance practices, and you speak to that, to your guidance practice when you get input from folks moving forward?
As I think you know, there's a draft guidance that's put out, and then comments are achieved from the public, really, at that point. But during the course of drafting guidances, we may have discussions with interested parties. And many of our guidances, you know, deal with the medical products industry, for example, and we do talk with people because we can't do these things in a vacuum.
Okay, thank you. And Dr. Walensky, I only have about a half a minute, so I'm gonna try to get my question quick. But we talked a little bit about mission creep when CDC is the pandemic preparedness and response, and CDC over 100 years since we've had our big, last big nationwide pandemic, and just the response to CDC prepared for a pandemic. It wasn't prepared, it did appear at the very beginning. Is it prepared now for another?
A lot of what we are doing in CDC moving forward is strengthening our piece or component that's a response-based agency. We have a new CDC Ready Responder program. What we could really use from Congress is the workforce authorities to be able to do that. Workforce authorities that are similar to other response agencies like FEMA, work for danger pay, overtime pay, loan repayment, tax-free loan repayment. So those workforce authorities would be really helpful for us to be even more ready to respond.
I'm sorry, 5 minutes goes fast. I yield.